So I'm going to talk about the current endovascular management of acute DVT and sort of some of the newer devices. So DVT, why do we treat? Obviously, first and foremost is to prevent PE. The less obvious, or which used to be the less obvious, was to prevent devastating consequences of lower extremity venous hypertension. I think Dr. Kim showed some great cases of sort of different types of venous ulcers. And that's sort of defined as prolonged swelling, debilitation, pain, and lung ulcers. And this can lead to a lot of work, loss of work for healthy individuals. So again, post-thrombotic syndrome is chronic leg heaviness, leg aching, venous claudication, edema, venous varicosities, and skin changes. So conventional therapy for DVT, as you guys all know, it's basically some sort of anticoagulation. It's risks include, basically bleeding, and then elastic compression stockings. This doesn't work great. It does prevent PEs, but in terms of preventing post-thrombotic syndrome, it's not necessarily always the best for some of our patients. So you still have a decent rate of valvular insufficiency in these patients. Up to about 30% of these patients, up to 5 to 8 years, can get valvular insufficiency. So the first mainstay was just catheter-directed thrombolysis. So this is a patient from a very long time ago, because we don't really treat patients this way anymore. But she had IVC filter-related clot, and this is sort of the drawing. I'm not going to show you obviously the duplex, but this is the drawing that we get from our DVT study, and this is the MR venogram showing the clot extending from below the filter all the way down. She had very bad swelling. She couldn't walk when she came to see us. So again, we don't do a lot of runs or venograms. We just take lots of pictures with just injecting contrast, save some shots. We don't really want to expose ourselves to too much radiation. And you can see sort of the extension of the clot. She's prone, so that's why the left and right are flipped here. So what we did is we used ECOS catheters. And again, just to date this case, this is actually using urokinase. This is a really long time ago. I don't think you can get it anymore. Abbott stopped selling it. So again, it requires a couple of different infusions. So one is obviously the TPA infusion. You do need to keep these patients on some degree of heparin or anticoagulation afterwards, and you do need to use some sort of coolant via the side port. So in patients that have CHF or cardiac issues, you do have to be cognizant of the amount of volume that's going in, especially if you're doing bilateral. You can get up to about 100 to 120 cc's of fluid an hour just through the catheters. So just be cognizant of that. So again, we lysed her overnight, invariably, even with ECOS, so the ultrasound-assisted catheter-directed thrombolysis. There was still a lot of chronic clot. Some of this is probably more subacute. And again, at this time, there wasn't really a lot of other options. This is sort of a filter that at the time we were not removing. And so we just stented and ballooned, and she got a good result, and 6 months her DVT symptoms went away. So again, catheter-directed does work. It does require, the problem is it has its drawbacks, right? There are long infusion times. We did this over 24 hours, but we've had patients that have needed 3 days of thrombolysis. That's 2 or 3 days within the ICU. Mean infusion times from the venous registry was about 48 hours, up to 80 hours of infusion. That increases your risk of bleeding, major bleeding complications. An ICU cost, right? So $10,000 a day for an ICU here in the States. So modern devices allow for near complete clot resolution, very similar to CDT done over 2-3 days. It can be done in a single session. Some of them do or do not require TPA. No ICU stay, and you can probably theoretically do these as outpatients, and we've done these as outpatients, and they can go home the same day. So these are the current devices that are basically more or less used. There are other devices. This is by no means meant to be exclusive. If I gave this talk 4 years ago, this list would be way shorter, and it'd be a much easier talk. Now there's all these devices that are coming out, so I'm not going to go through every device available. I'm going to go through these ones, because these are the ones that sort of we have on our shelf here. So Angiojet with Clot Hunter, Penumbra, Cat 8 and 12, and I think those two companies are here. Jedi Catheter, which is Abbott, actually they're here too. ClotTriever, which is Inari, and then the Aspirex, which is made by BD. So the Angiojet catheter, it's been around for a very long time, which was sort of one of our first sort of pharmacomechanical thrombectomy devices. There was the Trollis that came around at the same time, which actually was pulled from the market. Over some iterations, they've basically designed an 8 French device, which is this one, which basically it shoots, instead of being a circumferential shooting of the jet, it's a sort of an angled window. And so you get this very powerful jet that you can basically blow in TPA to get it into the clot. Usually we'll let it sit for a while. I'll go through our procedural steps, and you can then suck it out. They developed this thing called a clot hunter, which is probably the least engineered piece of equipment we have, but it's basically a bent wire that you can twist inside the catheter that basically causes it to get more excursion. So you can get a wider excursion in some of the iliac and IVC clot that they were running into issues with. So again, I'm not going to go into the whole thing, but it uses this Bernoulli effect to basically blow in fluid and then suck it back into the thing. So it causes basically fragmentation and then aspiration. It's relatively euvolemic, so you're not really sucking or removing a lot of blood, but you will get blood in the bag, which is the clot and the fragmented the fragmented fluid. It will cause their urine to turn red. It's not It's not bleeding. It's actually hemoglobinuria from the fragmented red blood cells. So this is a woman, 45-year-old, left lower extremity pain. She had previous stents that are occluded. This is just her CT scan. You can see her down left-sided stent. So what we did is we put her in the prone position, came from the popliteal. Since the popliteal vein was, so we did prone position, came from the popliteal vein, placed a 9 French sheath. We kept her on therapeutic heparin. Again, these procedures will fail if you do not keep them anticoagulated, so we do make sure they're fully anticoagulated as we do the procedure. So again, here's our venogram showing sort of extensive clot. A lot of the SFV clot had actually cleared up, but there was still clot in the common femoral vein, extending up in through the stents. We use the Angiojet here, and you can kind of see it. There's not much to look at. It's basically 2 dots moving up and down the screen. Not super exciting, but this is sort of our soup. 25 milligrams of TPA and 250 mLs of saline. We basically put it in power pulse mode, which blows in the TPA. We let it sit for about 30 minutes, then we come back and do the thrombectomy mode. This is what the clot hunter looks like. It basically causes the device to sort of swing around and move, so you get a little bit better excursion. And here you can see it coming down the superficial femoral vein. So again, we ran it for about 250 mLs. They have a limit, usually around about 400 is probably the limit that I'd run the clot hunter or the Zolante in a patient, because you can end up with some metabolic derangements if you go too long. And you can see here, basically even just after angioplasty, a lot of this cleared up fairly quickly. And just some angioplasty, and she didn't require any more stenting. She did well. Again, she was discharged the next day. So some other devices that are out there. So is the Penumbra Cat12 Lightning. All these devices are going to be described again tomorrow during the venous session, so I'm not going to go into too much of the nitty gritty, but basically it's a pump suction thrombectomy. It has this little ball wire separator to prevent the clogging, so you can clear the catheter. Again, at 12 French with suction at basically near vacuum, you can sanguinate someone, so you do have to be careful. With that, they created this sort of lightning system, which is sort of a mechanism to decrease blood loss. You can play with it back there, but it has like this clicking sound, which basically opens and closes the valve, so it sort of helps prevent blood loss, and it works well. This one's the Jedi catheter, which is made by Abbott. I think right now they're not distributing it, but they're sort of going back and forth, but it's coming. But basically it's sort of like a Penumbra in that it's a pump that sucks the stuff out, but then instead of using the ball occlusion wire, it has this little jet that sort of breaks up and fragments the clot as it comes in. It's supposed to be relatively euvolemic, so you're not really introducing a lot of fluid into the patient. And again, this is sort of their data, which is actually pretty good in terms of percentage clot removal relative to CDT and even the Angiojet registry from many years ago. The clot retriever, again, it's a 13 and 16 French device, a little bit bigger. Again, people have done these popliteal. I'm a little bit more skittish about putting in a 16 French sheath behind the knee, but people do it. You don't need to. You can also put the 13 French. It basically consists of this coring element, which is this sort of more open basket, which causes a lot of wall apposition, and then this basket, long nitinol basket that used to capture the clot, and it basically scrapes the wall of the vein and removes the clot. You can usually do it in about 2 to 3 passes. Here, very minimal blood loss. A lot of, like I said, 86% complete to complete clot resolution. Median blood loss was about 50 ml, so not a lot of blood loss, no TPA. So you can do these in patients who maybe can't get TPA. This one's relatively new for us. We haven't actually used this device yet, but basically it's the Asprex, very similar to the Rotarex. They sort of rejiggered it to make it work with for veins. It's a bit bigger. It's got some weird guide wires. So it comes with the 10 French requires a 025 guide wire, which comes with the catheter. They recommend upsizing the sheath. So even though it's a 10 French device, they recommend putting it through an 11 French because you do need to flush around the catheter. And it basically is an Archimedes screw that spins really, really fast. Sucks in clot and fragments it and actually removes the clot. Again, the data is relatively limited for this out of Europe, about 30 patients, but 100% technical success. The median runtime was about 5 minutes. And the volume aspirated, though, was still about 307 milliliters. So this doesn't actually introduce any fluid, so this is actual blood loss. So in conclusion, single session DVT, I think, can be performed relatively reliably. I don't think you need to learn every single device out there, but I think maybe pick one or two. They all seem to have an excellent safety profile, equivalent to better clot removal than CDT with no ICU stay. Again, multiple devices with different mechanisms of action. And then there are more devices coming. So this talk next year is going to be a lot longer. All right, thanks.